Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am thrilled to have Haley Lanoue here with us today. She is a TMC Vestibular Audiologist with our Adult Therapy and Audiology Department. And today she's going to be talking about Is Your World Turning? And vestibular testing. So I am so thrilled that you are here, and we're going to learn a lot more about what's entailed into vestibular testing and the balance clinic that we hold at TMC. Welcome, Haley.
Hi there. Thank you so much for having me.
So you may be watching us today on our YouTube channel or one of our Facebook pages. Please, if you have a question for Haley, please leave them in the comment section. And after Haley is finished, we'll go ahead and I'll make sure that we cover those questions for you. So please, Haley, I'm going to let you go ahead and get started.
Okay. So thank you for that introduction. My name is Haley. I'm a vestibular audiologist here at TMC. And I am located at the outpatient therapy clinic. There we go. So we are right across from the emergency department on the south side of Grant. And here we have vestibular evaluations with myself, the vestibular audiologist. And then we also have vestibular rehabilitation therapy offered by our physical therapists. So vestibular audiology vestibular audiology is an audiologist who is somebody who focuses on identifying causes of hearing loss, ear-related diseases, as well as dizziness, vertigo, and imbalance. What I do is I administer and interpret specialized tests relating to the vestibular system. And we'll go in depth onto what the vestibular system is soon. And then we also have physical therapy here, and these are therapists who specialize in helping you improve your balance, improve your dizziness symptoms, and overall improve your quality of life when living with any kind of balance or vestibular disorder. We work pretty closely together here at the outpatient therapy clinic. We're always kind of in contact with each other, which is a really nice aspect. And so, yeah, that's what we offer at TMC. So today we're going to go over quite a few things. It's a bit of a heavy topic, and I wanted to point out a couple of things. So this is going to be from the audiology perspective, focusing on dizziness, imbalance that's coming from your inner ears. There's a lot of things that can cause dizziness. As a disclaimer, I'm an audiologist. I have a clinical doctorate in audiology, but I'm not a physician. I'm not a medical doctor. So I'm going to be talking from the audiology perspective, but not so much the medical perspective. And as always, these are educational content, and dizziness can be a big symptom that I definitely want you to seek medical care if you're experiencing that. So again, this is education. And we're going to go over quite a few things today related to vestibular audiology. The first of which is who gets dizzy. So anyone can be affected by dizziness. We're going to be focusing on the adult population today, but anyone of any age can get dizzy for truly hundreds of reasons. Overall, with dizziness related to the ear, there is about, I think, 40% of dizziness, overall dizziness, related to the ear. It does increase in prevalence as you age. So the older you are, the more likely you are to experience dizziness at some point in your life. And about 4% of visits to an emergency room have a chief complaint of dizziness or vertigo. And one reason we talk about this so much is because dizziness is a major risk factor for falls, which can be pretty damaging. We want to avoid falls if we can throughout our lifetime, but especially as we age. So a few things before we kind of dive into it. I wanted to go over some definitions when we're talking about dizziness. Dizziness is often a very vague term that is hard for everyone to exactly know specifics on what you're talking about. So I wanted to address these at the beginning. So we're all on the same page. So when I talk about vertigo, vertigo is a sensation of motion when no motion is occurring. Most often people describe this as a spinning sensation. So they might see the room spinning around them, even though they're sitting perfectly still, or they might feel like they're spinning, even though the room is perfectly still. So one is an external where the room is spinning, or one is internal where you are spinning. But both of those are vertigo. It can also feel like a rocking or a turning sensation, such as you turn your head and you know your head stopped, but it feels like you're still turning. So that's what vertigo means. Imbalance is when you're not balanced. So you are unsteady on your feet. You are maybe kind of swaying from one side to the other as you're walking. You're just not quite able to stay upright. Unsteadiness, again, is just being unstable. It can be while seated, standing, or walking. Dizziness is more of a generalized term. When I talk to people, I often ask them to describe their symptoms without using the term dizzy because it is so vague and can mean so many different things. But the actual definition is, sorry, got locked out of my computer real fast. Dizziness is a sensation of disturbed or impaired spatial orientation without vertigo. So this might just be a vague sense of dizziness, but you're not having any spinning or rocking sensations. And then lightheadedness is a woozy sensation or feeling like you're about to faint. So most people describe this as when they get up too quickly and they feel kind of woozy. You feel like you might have to sit back down, or you might lose consciousness or pass out. So those definitions are all, a lot of people describe them interchangeably, but those are important differentiations. Your balance system, which encompasses how you're able to stay upright, is made up of three main components: your vision, so what you can see; your proprioception, which is your touch and feel, so feeling the chair behind me, my feet on the ground; your vestibular system is in your inner ear, and that helps you detect your head motion and where you are in relation to gravity. And all of those three components are integrated in your brain, and then that is what makes up your balance system. And so the next slide just kind of has a visual of those. If we go to the next slide, there we go. So your eyes, your ears, your touch, and your brain all make up your balance system. And again, today we're going to be focusing on the ear. Since I am an audiologist, I talk about the ear. This is a picture of your ear. So what is highlighted here is your outer ear. That's the portion you can see. That goes your ear canal down to your eardrum. The next portion of the ear is your middle ear. Next slide, please. All right, so your middle ear there has three little bones, and it's in an air-filled space. And that's actually connected to your sinuses through something called your eustachian tube. So that helps regulate pressure, like if you're going up in an airplane or over a mountain pass. And then your inner ear has two main components. One is the cochlea, that's the spiral shape on your screen, and that helps detect sound, and that's what you mainly think of when you think of your ear. But the other part of your ear is your vestibular system, which is those three kind of loopy guys on the top of the screen. And then your vestibular system, this is a diagram of it here. It is a fluid-filled membranous labyrinth. So it's all encased in bone, and there's various components all filled with fluid. You have one on each side of your head, and they work together to act as a paired system, almost like an internal gyroscope, to figure out where your head is in space whenever it moves. So the first part of the vestibular system are the semicircular canals, and Those help detect angular velocity. And then there's two other portions called your otolith organs, and they help detect gravity. So the semicircular canals, next slide, please. The semicircular canals, they sit all at 90-degree angles to each other on each side of your head. Again, they're fluid filled and they work in a push-pull mechanism. So when you turn your head, that fluid moves and it pushes on one side and it goes away from the other side so that your head can tell which way you turned. When you turn to the left side gets excited with that fluid rushing toward it, and the right side gets less excited. Then when you turn toward the right, the same thing that way. And those three canals work to detect wherever your head is moving. And then the next portions are something called the otolith organs. So these are little gel-like membranes, and on top of that membrane are little crystals. So you kind of do have rocks in your head. Those crystals are sitting on top of the gel, and whenever you move forward or backward or up and down, those crystals help detect where you are with gravity. So the crystals in your head help you detect gravity. The utricle goes in the horizontal plane, so forward and back. And then the saccule goes in the vertical plane, up and down. All of this is to say it's a complicated system, and I don't expect you to really memorize all of that, but the vestibular system is very important for your balance and knowing where you are in space. All of that is sent to your brain through something called the vestibular cochlear nerve. So this is a cranial nerve that comes from your brainstem, and it attaches to the vestibular system with two branches, and then one branch comes from the cochlea, or the hearing portion. So the cochlea plus two from the vestibular system all form together to form the 8th cranial nerve. That then goes through your brainstem, your cerebellum, and your cerebral cortex. So your ear information goes through the nerve and through the brain. And the purpose of this whole system and the function, the purpose of the system is to detect head motion and where your head is in relation to gravity. So next slide, please. Here we go. And then the function is, there's kind of 4 main functions. It stabilizes your gaze. It controls your posture. It provides information for where you are in space. And it helps coordinate your head and body movements. And it does this through 3 main reflexes. So that inner ear system, one of its main functions is to stabilize your gaze. It does that through something called the vestibular ocular reflex. And that basically means that when your head moves, your eyes move in an equal and opposite direction. This is going to be kind of weird, but if you look at my eyes, I'm able to keep my eyes on the camera while I move my head, and I can still see a stable image. And that's because of the connection of your ear to your eyes through those central pathways. Another one is the vestibular colic reflex, which your ear sends signals to your neck to basically just kind of keep your head stable. So this is kind of one of the reasons when you go running down the street, you can still see in front of you, your head knows where it is in space. And then your vestibulospinal reflex helps keep your center of gravity. So it helps keep your head over your center of support. So whether you're sitting or standing, it just helps you tell where your head is compared to the rest of your body. And so all of these help to maintain you upright. It helps make sure that you have background muscle tone so that you're holding your core up when you're sitting up, you're standing, you're not just flopping over. So it's all kind of a complicated system and pretty integrated, but the vestibular system gives a lot of information for you to stay upright. What I'm going to mainly be talking about today is what we consider the peripheral vestibular system. So that's the 3 semicircular canals, the two otolith organs that sit in your inner ear, as well as the first portion of that vestibular nerve. The other part of your vestibular system is called the central system, and that's anything beyond the nerve. So once that signal gets to the brainstem and it goes up through the cerebellum, the brainstem, and the cortex, it connects to your eyes so that your eyes are moving as well. That's all what we consider central. There was a talk in September of 2021 for TMC for seniors, and that goes into a lot of detail on central causes of dizziness and vertigo. I believe it was August 21st of 2021, and Fran West gave it, titled As the World Turns. So we're not going to go too much into the central causes today, but I think if you are interested in that, that was a great talk that reviews a good amount of that. Again, we're going to focus on the ear today. So when we're talking about people with symptoms of vertigo and dizziness and imbalance, there's some symptoms that indicate something is more peripheral related to the ear versus something more central related to the brain. Again, there are hundreds of potential causes of these, and there's almost an exception to everything that I say today, so we're just going to go into generalizations. But something going on with your ear usually results in true acute vertigo, so true spinning sensations, things like nausea, vomiting. You might have ringing or fullness or pressure or hearing changes accompanying those symptoms. Any of those usually indicate it's related to the ear, whereas central is more things like general dizziness, lightheadedness, weakness, imbalance, something called oscillopsia, which means you're not able to stabilize your gaze. Everything looks like it's bouncing around. And one thing I wanted to mention is your inner ear does not cause you to faint or pass out. So if you're getting dizziness and then you're losing consciousness, that's not something related to your inner ear. That's definitely something else going on. So we want you to get evaluated by a medical professional as soon as possible. So if you are having these dizziness symptoms, one person you can go see is a vestibular audiologist. For vestibular audiology, we do something called a vestibular evaluation. And the purpose of this is to test the function of your vestibular system. So looking to see how that inner ear is working, how the central system is working, and to rule in or out if the ear is involved in your symptoms. It's important when looking at anything related to dizziness or balance that you work in an interdisciplinary team. So as an audiologist, I kind of work to gather diagnostic information, again, on the function of your symptom, whereas a physician is going to help figure out the underlying cause or the underlying etiology. So what kind of disorder might be happening that's causing the dysfunction, and then also help manage that medically. And then physical therapy and occupational therapy are going to help provide rehabilitation. So improving the overall function and then helping with quality of life. So audiology gathers diagnostic information on the function, the functional status, a physician diagnoses, and then a physical therapist or occupational therapist helps improve that function. So who should seek a vestibular evaluation? Like I said at the beginning, if you're having any dizziness, imbalance, vertigo symptoms, please go see. I would start out with your primary care provider, and they can help kind of direct you. But a lot of people just don't know why they're dizzy, and I would say it would be a good idea to get a vestibular evaluation in that case. So if you're not sure why, you've seen your primary care provider, they're not sure what's going on, or you've been in treatment for something and it's just not really working, symptoms just keep going on, that's a good time to come and see a vestibular audiologist to see if there's any other answers we can uncover there. Other times, as an ear, nose, and throat physician might refer you for vestibular testing, or a neurologist might refer you for vestibular testing. But definitely start by talking to your primary care provider. Other things are if you have any other ear symptoms like ear pain, ringing in the ear, hearing loss, definitely go to an audiologist or an ear, nose, and throat physician as well. So what is included? So what's going to happen if you have these symptoms and then you come in for testing? We're going to start off by doing a pretty comprehensive case history and questionnaire. And then we're going to do these other tests. I'm going to go into detail about them. That's essentially, again, looking at the function of your inner ear and the function of the central system. So first, with that case history, next slide, please. So we're going to go into the characteristics. So that's where those definitions at the beginning are important. Is it spinning sensation? Is it a lightheadedness? Is it an imbalance? Is it constantly there? Going into time course of it, does it come on for seconds? Is it always there? Minutes to hours, hours to day? Any associated symptoms, if anything brings it on. Some things might be movement, getting into or out of bed, loud noises, weather changes, diet, medication, talking about any other symptoms and any other medical history you have. One of the most important parts of a vestibular evaluation is this case history, because so much of any disorder or any kind of diagnosis relies on those symptoms. And so we're going to spend a good amount of time talking about those symptoms to make sure that we're getting all the information we can to get you to the right place, to get you the best treatment. After that, we're going to do something called video nystagmography. So that's a big word. It is shortened to VNG, and that basically means we're going to record your eye movements in various conditions and positions with some big goggles. So I have these with me today. Back here is where I actually do the testing. So you end up sitting in this big chair looking at this television behind me, and then you wear some big funky goggles, and they have cameras and lenses in here so that we can record your eye movements. We record that pupil because, like I mentioned at the beginning, your eyes and ears are very well connected. So when your ears tell you your head is moving, your eyes move equal and opposite. So with this, we're going to test how your eye moves alone without moving your head in various conditions. Then we're going to test you by moving your head in different positions. This is to look for positional vertigo. So this might be a time where we kind of try to make you dizzy to see what part of your ear might be impacting that dizziness. And then we're also just generally looking at the vestibular ocular reflex, how your eyes are moving compared to your head. And then something called the otolith ocular reflex, how those the utricle and saccule, the ones with the crystals, also affect your eye movements. Then we go on to something called caloric testing. So we're going to put warm and cool water into your ear canals, and this stimulates each ear independently. So at the beginning, I mentioned it's a paired system. Whenever your head moves, one is getting excited and one gets inhibited. And so with the cool and warm water, we're able to separate those ears out. And this is our only test that can test one ear completely separate from the other. When we put a different temperature water into your ear canal, it actually makes you dizzy. And we're looking for your eye to beat in a rapid eye movement called a nystagmus. So your eye will move in a specific direction once we put this water in. And then you start to feel more and more dizzy, and then it kind of reaches a peak, and then you start slowing down again. Some people say it feels like they're on a tilt-a-whirl. Some people feel like they're just spinning nonstop. You're sitting perfectly still. It's a pretty weird situation. But then once that ear comes back to room temperature, you stop spinning. We wait a while, and then we test the other ear and then we do the same thing with the other temperature water. And with that, we're really looking to see how each ear is working, if there's an asymmetry, if both of them aren't working, or if both of them are giving too much input. And again, we're looking central or peripheral. So is it the ear, or is it something else in the brain or the central pathway happening? The next one is called VEMP, or vestibular evoked myogenic potentials. The utricle and the saccule, the ones with the crystals that detect gravity, when you present the ear with a really loud sound, those actually give feedback to your muscles and they contract. And we're able to measure that contraction with electrodes that we place on your neck and then underneath your eyes, and we can infer how those two organs are functioning based on the response we get from that electrode. These give us a lot of information on those two systems, and those results are really helpful in narrowing down a diagnosis for you as well. And then after VEMP, we have something called VHIT. So this is video head impulse testing. It's not as scary as it sounds. We put another set of goggles on you. So it's a smaller set of goggles, but they have to be pretty tight to make sure that this doesn't move around while your head moves. And then I stand behind you and I gently rotate your head like this to see how your eye moves. You focus on an object in front of you and we see if your eye can stay there or if it can't stay there. The overall function of this is to test each of those canals, and we can get information from each ear. So we test the horizontal one, which is this motion. We test the posterior and anterior canals. So posterior is your head going back, anterior is your head going forward. And then we test the other side like this. And all of that information we put together with the rest of the testing to see what of those 5 portions of the inner ear are impacted, if there's something going on in those central pathways that go from your ears through your brainstem, cerebellum, and your eyes, or if there's some combination of the two, or if there's no findings at all. A lot of vestibular testing is also figuring out what's not causing your symptoms to narrow it down to get to what might be causing your symptoms. The last portion is an audiologic evaluation. So this is a comprehensive hearing test. We'll test how well you can hear the pitches, test your speech understanding, and then also test the function of your ear, if your eardrum is moving well, because your ear, again, is connected. That cochlea, the spiral that senses hearing, is really well connected, both with the fluid in the ear is all connected with the vestibular system, and they share that nerve. So it's important to get a whole picture of how the whole inner ear is working, so that we can kind of put it all together and figure out where the dysfunction might be coming from. So when it comes to your ear and vestibular symptoms, there's kind of 4 top diagnoses we call the big 4 that cause dizziness. Those are BPPV, benign positional paroxysmal vertigo, Meniere's disease, a neuritis or labyrinthitis, and then a vestibular migraine. Overall, of people with dizziness, about 44% of them actually have something related to the inner ear. And these are the most common ones that are related to the ear. But like I said, there can be hundreds of causes. So if we go, there we go. So these are just kind of some of the top causes of dizziness related to peripheral and central findings. There are so many more. So it's a lot of them kind of masquerade as one another as well. So if you're having any symptoms, it is important to get evaluated, and you might end up in my office one day. So BPPV is by far the most common cause of vertigo. So BPPV stands for benign, it's not life-threatening. Paroxysmal, it comes in sudden, brief spells, typically less than a minute. It's positional, so it's triggered by a certain head position or movement. And vertigo means it's that true spinning sensation or false sensation of movement. So most often people say that they rolled over in bed and all of a sudden the room was spinning, but it only lasted for about 30 seconds and then it went away. It might happen every single time you move your head in a certain position. It might be looking up to get something off a top shelf, washing your hair in the shower, bending over to pick something up, a quick head turn. Those are a lot of the common symptoms of BPPV. What's happening is the crystals in your ear that are supposed to be stuck to those gel-like membranes can come loose. And they can come loose for a number of different reasons. And they come loose and they go swimming around in those canals. Those canals are fluid filled. And so whenever the fluid is moved, that's sending a signal to your brain that something is happening there and that you're turning in some way. So if you roll over in bed and that little crystal goes swimming in the canal where it's not supposed to go, it's going to push that fluid, and that fluid is going to send the signal to your brain that you're spinning. But the rest of your body is saying that I'm sitting still, or I only moved a little bit. And so your brain is going to start feeling like it's spinning, even though you know that you're sitting still. And then once that crystal kind of settles into place, it's going to go away. And then it can happen when you move back again. It can happen just once. It can reoccur several times. Sometimes it goes away completely on its own. Most often it does have to be treated, but the treatments are pretty quick and pretty effective. This accounts for about 50% of all dizziness that people experience. It does go up as you age. So the older you are, the more likely you are to have BPPV. And then, can we actually go back a slide real fast? Thank you. There are some things that can also increase it. So head trauma, if you have a concussion or a traumatic brain injury, you're more prone to this. Inner ear infections, diabetes, osteoporosis. There's a number of different causes. But what happens is once we figure out what this is, we can do a quick test by putting you in a position called the Dix-Hallpike or a head roll test. And we can look at those eye movements to see what canal is affected. And once we know what canal is affected, we can roll your head to get those crystals back into place. And the majority of people experience their symptoms stopping after this. So again, it's benign, it's quick, it can feel pretty debilitating, and some people experience a lot of symptoms after that spinning stops. It's not fun, but it can be treated. So definitely if you're experiencing that, there's treatment. So come in to primary care, physical therapy, audiology, and we can help you out there. The next one is something called Meniere's disease. Meniere's disease has a pretty specific set of symptoms. The first is vertigo, occurs randomly from 20 minutes to 12 hours at a time. You also have a fluctuation in hearing loss, so you might have less hearing, a feeling of fullness or pressure, and tinnitus, so ringing or buzzing or roaring in your ear, all kind of with the same span. So some people get the vertigo first and then the ear symptoms. Some people get the ear symptoms and then the vertigo. Some people get it all at once. There are some triggers of this, such as a high salt diet. If you have a lot of sodium, it can increase it. Allergies, stress, fatigue, pressure changes. So there's a lot that can trigger it. There's a pretty specific set of symptoms. If you think you're experiencing this, you definitely want to see an ear, nose, and throat provider. Meniere's disease, there's no definitive cause. So it's thought to be due to an abnormal fluctuation of the fluid in that inner ear, creating a pressure, which you would feel as pressure, and then creating that vertigo. And then if we go to the next slide, it again is one of the more common causes of vertigo. It can occur at any age, but it's typically between the years 40 to 60 years old. It's typically progressive, so it starts out as maybe more frequent episodes of vertigo that you're free of symptoms in between, but then it can progress to just a complete loss of hearing or a loss of vestibular function on one side. It's usually in one ear, but it can occur in both ears. And treatment can be anywhere from stress reduction, diet restriction, so limiting your salt intake. There are certain medications that might help with this, vestibular rehabilitation to help manage some of that imbalance or vertigo symptoms. And in severe cases, you would work with a surgeon and they might have more permanent treatment options for you. The next common cause is called a neuritis or labyrinthitis. So this is an infection of the inner ear. It's typically an infection of the nerve. Usually it's viral, so any viral illness can cause this kind of infection, but it can be bacterial as well. What usually happens is you have a very sudden sensation of vertigo that lasts usually over 24 hours. And it's usually pretty severe. It can be mild, but most people say, I woke up, the room was spinning, I couldn't get out of bed, I was really sick to my stomach. A lot of people vomit, and then a lot of people do end up in the ER or emergency department with this. A vestibular neuritis means only the portion of the nerve that goes to the vestibular system was impacting, resulting only in that sudden vertigo or dizziness. A labyrinthitis means it impacted the whole nerve, so it can result in hearing loss, tinnitus, and vertigo or dizziness. It usually starts out pretty debilitating, and then over the course of usually roughly 6 weeks, you start to progressively get better and you improve your balance, and then you start not being quite as dizzy. The prevalence of this is about 3.5 people in 100,000. And it can occur at any age. Again, any kind of infection of the ear can cause this. Treatment, you definitely, if you have any kind of sudden hearing loss or sudden vertigo, especially if it's severe, you can't sit upright, you can't move without getting sick, I do want you to seek emergency care. Because they are going to help rule out if there's a stroke or if there's something else serious going on in that central system. And they can also get you right over to an ear, nose, and throat doctor because we want to start treating this as soon as we can. Next slide. Oh, I already talked about all of that. But some of the treatments include like steroids to help treat the viral infection or reduce inflammation, and then vestibular rehabilitation to get you into therapy, to get you moving as soon as you can after that attack occurs. And then the next most common one is vestibular migraine. So vestibular migraine is a bit of a complicated one. Migraine can cause all sorts of different symptoms. It can cause things like phonophobia, where you're sensitive to light or sound. Phonophobia is the sensitive to sound. Photophobia is sensitivity to light. It could cause a visual aura, so you might see like a flashing or a bright light with it. But one of the other symptoms that migraine can have is vertigo. It can last anywhere from 5 minutes to 72 hours or sometimes even longer. People with definitive vestibular migraine have a current or previous history of migraine. So this is based off of the International Classification of Headache Disorders of migraine. And then with the vestibular symptoms, at least 50% of these attacks occur either with a headache, with photophobia, or a visual aura. And there's not a better accounted vestibular diagnosis for it. Probable vestibular migraine is you've had at least 5 episodes of these symptoms, but you only meet one of the criteria of the phono or photophobia, the headache, or the visual aura. You do not actually have to have a headache with a migraine. Oftentimes, about a third of people with vestibular migraine don't experience any headache with their vestibular symptoms. Some people experience it before or after the vestibular symptoms, but some people don't experience the headache at all. It affects about 1% of the adult population. There is a pretty significant female to male predominance. So females are more likely to get it, mostly because females are more likely to have migraine compared to males. And of people with migraine headaches, about 23% of those people have vestibular symptoms at some point in their migraine course. You might also have positional vertigo, where if you lay down, it might kind of mimic BPPV, or you might also have BPPV with these symptoms. And treatments include treatment for migraine as well as vestibular rehabilitation. So again, there are a ton of causes. We could be here all night if we wanted to, talking about the different causes. It's important for you to definitely seek medical care. Again, a lot of these require someone really well versed in these to be able to differentiate those symptoms. Someone might be having vestibular migraine, but somebody might classify that as only BPPV, even though they might be having both, or it might just be the vestibular migraine. If you're having any sudden change in symptoms, like a sudden severe episode of vertigo, definitely go to an emergency department, because there is a possibility it could be related to a stroke or like a cardiovascular change, and you want to get evaluated as soon as you can by a medical provider. So what next? If you're having symptoms of vertigo, imbalance, dizziness, if we go to the next slide, you might be referred. Definitely start off with your primary care physician or provider. They might refer you to an ear, nose, and throat physician who's going to look medically at the ear, and they might recommend the vestibular testing. You might be recommended to neurology if there's signs of any central involvement. Cardiology, again, like I mentioned, an inner ear problem isn't going to have you pass out. So it might be something related to blood pressure, something we call orthostatic hypotension, which is a drop in blood pressure when you get up, creating that woozy, lightheaded sensation, or vestibular evaluation. So if you see me for testing, I'm going to be, again, looking at the function of your ear, if it's central or peripheral, and I'm going to help guide you to where you should go next. Or we're just trying to see the function so that we can help improve your vestibular rehabilitation. So vestibular rehabilitation is usually with a physical therapist, but can be with an occupational therapist as well. It's a customized treatment program to help improve your dizziness symptoms, regain, improve, or manage your balance function. So there's various exercises, both physical, where you're like really moving your body, and other ones you're just doing kind of small things that don't seem like it should be very significant, but it is. So things like making sure that you're integrating your visual input well, being able to focus on something while you turn your head. They're going to be working on building that function up for you, making sure you can balance in various situations on hard surfaces, soft surfaces, unpredictable surfaces, and they're going to really work with you where you are to get you to the best function that you can. One important aspect of any kind of vestibular rehabilitation is consistency. If you have something going on in your peripheral vestibular system, say you have one ear that's not working as well as the other, your brain is constantly working to integrate that mismatched signal to make sure that you're not dizzy all the time. And that takes working on it every day. So you want to make sure you're staying up with those, any kind of therapy program that you have. Things like walking regularly can help, because you want to be working that to make sure that those pathways are working well. Whereas if you all of a sudden aren't mobile anymore, say you're not able to move as much as you once were able to, whatever function you had at first, when you stop doing things like you stop moving your head, or if you stop walking, or anything like that, when you start doing those things again, it's going to take a lot of work for your brain to kind of get back to its baseline. You might have more symptoms if you take a big break from your therapy. So definitely consistency is key with any kind of therapy, making sure we're not limiting what we're doing and we're doing as much as we can that's safe and comfortable for you. So the next slide, I have a few resources. Again, there can be so many causes and there's so much information out there. So I wanted to give you a couple of places you can go and look up some more information for yourself. One of those is VEDA, the Vestibular Disorders Association, can be found at vestibular.org. They have a ton of really user-friendly kind of guides, what different disorders are. It goes into what vestibular testing is, what vestibular rehabilitation is. I think they're a great resource to check out. The LABYRINTHITIS Society is working on making an international classification of vestibular disorders to make sure that all the physicians and medical providers you see are on the same page. That's a lot more kind of medical jargony, but if you're looking for some research papers, that's a good place to go. Dizzinessandbalance.com, again, is a good place. And then the American Speech Language Hearing Association and American Academy of Audiology are both certifying boards for audiologists, and they have some great information as well. So if you think you need a vestibular test, if you're having symptoms that aren't explained by anything else, or you're having some of those symptoms I talked about today, you can definitely get scheduled, but we do need a physician referral from you. So you do have to see a provider, whether that's your primary care provider, an ear, nose, and throat physician, a neurologist. They do have to send a referral over to us so that we can evaluate you and then start seeing you for physical therapy as well. Again, we're located right across from the emergency department at the outpatient therapy clinic. And that phone number there goes straight to outpatient therapy. So if you have questions on how to get scheduled or how to get a referral, you can call us there. And thank you for having me today. I know it's a big topic. Hopefully that gave you some good information.
So thank you so much, Haley. I mean, there was a lot of information in there, and I had no idea how many things could affect, your vestibular. So I'm so glad to learn more about it. I did have a question. If you were to have sort of recurrent inner ear problems, would you be going for vestibular testing more than once, or would that change over time, or would you typically only need to have that done one time?
That's a great question. It can be both. So most people who come for vestibular testing, it's really looking to figure out, is it related to the inner ear or is it something else in those central pathways? And so for the most part, it's one time to figure out where the problem is lying, and then you go on to something like vestibular rehab or seeing a specialist like an ear, nose, and throat or neurologist. But occasionally, there are some things that we might want to monitor regularly. So something like a neuritis, we might do at the beginning when you have a sudden episode of vertigo. And then say you're not really getting as function back as we think you should, we might do that again later on to see what problems are still occurring. We might also track things like traumatic brain injury can cause imbalance, and the vestibular testing can help kind of track your progress and see where those symptoms are still most difficult, or where we kind of need to refocus our therapies. But for the most part, people just come to see me once. So it's a lot of testing. It's about 2.5 hours of testing total. It's pretty involved. Usually people are pretty tired after, so most people only come to see me once.
Okay, and I was going to ask you how long that testing was. So about 2.5 hours. And
Mhm.
then so then usually if, let's say, somebody is diagnosed and they're going to continue on with treatment, how long does that typically, what does that look like? What is that time period like, or what's the span generally?
Um, it depends, honestly. Some people, if it's something, usually things that are related to the peripheral vestibular system, so something going on in the ear, those people are typically in therapy for probably 6 to 8 weeks or so, and they usually kind of get going pretty fast after that. The people who have mixed, so something in the ear and something central, or just the people who have something central going on, usually takes a little bit longer for therapy to really kind of ramp up and be able to really start impacting your daily life. So it really depends on the person. And again, that consistency is key. Um, so I would say probably about 6 weeks is on the shorter end.
Okay.
Some people with like BPPV, it might just be one treatment and then we're done.
Okay. I do want to put up, I know you mentioned where you can call, but I'm going to also put the information up here. So please, if you're looking for information or would like to schedule something, the number is 520-324-7005. A physician referral is required to utilize these services, and they are located over off of Erickson, just across Grant, on the other side of the hospital there. So they've got a great space over there. We've actually done some fall prevention testing with PT in that space, so it's a really great space as well.
Mhm.
I do have, let's see, I have one more question that says, um, was talking about a vestibular balance issue that was developed from chemo-induced peripheral neuropathy. Any comments on that? On
So that can be a couple things. So peripheral neuropathy means that you're losing the sensation of feeling. It might be in your feet, it might just be touch in general. Um, if you don't have that peripheral input, so the touch from the bottom of your feet or that proprioception, that's definitely going to impact your balance. So that wouldn't necessarily be related to your ear, but can definitely impact your balance. And you would definitely want to be working with your physician and probably physical therapy as well to help improve those. The other thing, some chemotherapy agents can impact that vestibular system itself, which can cause reduced function. And then that's when you would likely end up in my office and then also physical therapy as well. So certain chemotherapy and certain like strong like IV antibiotics can actually reduce the input from the vestibular system.
Okay, thank you. All right, I want to thank you again for being here today. That was great. Lots of information. I know if people are interested, you're always willing. We're happy to send out your slides
Mhm.
so people can sort of review back as well
Yeah.
on everything that could sort of be covered, whether it was peripheral or central. So it might be helpful. So please let us know if you are interested in that. And thank you for being here, Haley. I look forward to seeing everyone again in June. Our next topic will be on June 7th, and it will be Don't Be Caught by Scams or Fraud. So we will see everyone then, and thank you all for being here today.
Thank you.